Hi, everybody. Welcome to the Operations Committee meeting, the subcommittee of the Universal Health Plan Governance Board. I'm not Bruce Goldberg. Unfortunately, he's not able to join us today, so I have the honor of chairing this meeting, and I'm so glad you're all here. Isabel, would you provide a roll call so we can see who all is?
I can. I'm just making sure that I've got everybody that I need to have. There's one more person in the waiting room that I'm just letting in, and then we will kick off our roll call. Okay, so as you said, Bruce Goldberg is absent today. Judy Richardson,
Here.
thank you. Laura Byerly, I do not see Laura yet. Doug Flo, I do not see Doug yet. Sarah Fouché,
Here.
thank you. Lori Hoagland. I see your video, but I don't hear you yet. Looks like Lori's connecting to audio, so I'll come back. Michael Hore, I don't see Michael yet. Doris Karagu,
Here.
thank you. Rosalind Lindsay, I don't see Rosalind. Anne Lovejoy,
Here.
thank you. Paula Weldon,
Here, sorry.
no problem. Thank you. And then Lori Hoagland, are you able to, can we hear you? I see you. It looks like there's some technical difficulties, but we see you. And yeah, that's everyone.
Thank you, everyone, for carving some time out of your busy and important days for this lovely meeting on a gorgeous autumnal fall, September 25th. And to members of the public who are tuning in, thank you for your interest in our work. And for those of you listening to this after listening to the recording, thank you also. So take a look, we can take a look at the agenda. Really, it's a very tight agenda today. Mostly, we're going to be listening to the proposed straw proposal, preliminary proposal about the administrative structure. We'll have some reflections about that content. We would like to move that to the board if the committee is ready at this meeting. We'll have some public comment and adjourn. Is everyone all right with that agenda? Any changes to the agenda? Great. Okay, Isabel, next slide. Committee updates, is this you, Mimi?
This is me.
Thank
So
you.
good afternoon, everyone. This is Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. So bringing some updates to this committee about things that are happening at the board level and also at the other committees, so we can kind of work on aligning all of the work that's happening in these various presentations. So I will say at the most recent board meeting, we had a presentation from Milliman, which is, you are aware, is our new sort of large consultant group that is assisting with a lot of the groups, including this one, the operations committee. There was also a great report out on hospital payment models. There weren't any proposals that were put forth at the board meeting at the last meeting. However, I want to give a teaser, as it were, for this upcoming board meeting, which is just for folks, it will be on October 16th. So at that point, there will presumably be a straw proposal about the revenue strategy. Also, presumably about administrative structure and regional entity model, which we'll take care of at this meeting today, and also a proposal about a quality strategy. So the board is really starting to, as all the committees are really bringing together these proposals, then they're coming forth at the board level. So things are moving along. So speaking of things moving along, definitely finance and revenue, the revenue strategy, it's gone through a couple of iterations. The next finance and revenue meeting is on, I'm looking over at my calendar, is on October 7th. And so once again, sort of in even more close detail, the proposed revenue strategy will be brought forth and discussed amongst the committee. And then again, there is a straw proposal put forward, and we'll see if that makes it through the committee and goes up to the board level. There'll also be some discussion of the impact of the proposed plan on individuals and households. So having a better sense, the plan is to have sort of different scenarios, say people sort of either an individual or two people living together, or people who have dependents in their household, what it will look like with a new revenue strategy. So that's coming up. Plan design and expenditure is coming along in next week. There'll be a quality proposal that's coming forth. There will be not proposals, but just further refinement on hospital payment systems. And then also kind of bringing back behavioral health. The behavioral health system work has occurred at that committee level previously, but it was more in terms of the benefits that were desired. So this time we're doing a little bit deeper dive into what's happening with behavioral health payment systems. So that's it. And then community engagement and communications. We just had a great meeting yesterday when actually we were talking about different types of questions for those different engagement groups when those meetings are going to occur. There has been a ton of work and almost completely ready for prime time. The strategic messaging guide, some one-pagers, and some FAQs. So CECC is doing just a tremendous amount of work. So I'll pause. I'll ask Judy Richardson, any other things that you want to say maybe about the board meeting or where we're at?
No, I think this is good. And just for the committee, I want to give a big shout out to Mimi, who is really the super glue that keeps all of these committee pieces and deliverables together. Without her, we would be kind of all floating, I think, rudderless. So thank you very much for all of that. Any questions for Mimi? Lots of great work going on in all of the committees and at the board level too. Thank you.
Thank you. You know, it's not just me. It is Isabel, Mimi, and Lee. We're a team.
Yes.
I could not do it without them. I did just this next one. It's sort of this very committee update. So if you go on to the next slide, this is not anything that anyone has to study or, but it's one of the ways that we're keeping track of where we're at with our deliverables, just to make life a little bit easier as we, are pulling together our report. So you can kind of see, all right, so with administrative structure, what have we done? We did, we had these a couple of presentations. Now we're at this portion of having a preliminary proposal. Then we have what we are hoping is our committee final timeline, and then will be the board final timeline. So just like I said, just to kind of people to sort of get a sense of where things are at with this committee. And again, we don't play favorites, but I will say this committee is doing very well with getting things done. So you can go on to the next slide. Thank you so much.
Great, thank you. And I'd like to hand it over to Senior Policy Advisor Hastings for the presentation of the administrative structure. Hopefully you all received this prelim proposal in your inboxes, but Lee will walk us through it. Take it away.
Yeah, thank you for that. Yes, so there's quite a bit more, of course, in the proposal, but as you go to discuss it and offer us any feedback and hopefully allow us to pass this on to the board for their feedback, I did just want to give kind of a reminder of where we've been and then really the key elements that are contained within this preliminary proposal. Next slide, please. So our guiding framework, this figure on the what is that? The right really shows, this is the structure that that Mimi had located related to those levels of involvement that are possible when you're looking at sort of this conversation really all began talking about these regional entities or regional bodies. What were they going to look like? What was their role going to be? And a range of roles going from those that are fully responsible in a decentralized model to those that are simply informative in a really strongly centralized model. And looking at what we have and what has been proposed by the Joint Task Force, it was really very clear we were looking at something in that accountable to advisory range. So that informed a lot of kind of the decision making around what functions should sit at a regional level versus at a centralized level, knowing that we wanted something that was kind of in the middle, but maybe leaned a little more central. Yeah, some of the other guiding framework things just from conversations that the board had pretty early on about regions. Specifically, some concerns came up related to what we currently have in the Medicaid space, which is the CCOs, but not wanting to have some of those overlapping regional boundaries and concerns about the possibility that there could be for-profit entities there. There's also really strong consensus amongst board members, as well as, I'll note, just members of the public that did offer comments as well, that risk should be borne solely at the central kind of public corporation level. So we used all these as our guiding framework. Next slide. This should look pretty familiar because we did present this to you at the last meeting in amended form. This has been updated to reflect the suggestions that this committee made. And I think this is a pretty good summary. It doesn't have every single detail, but I think it provides at a high level what we, the staff, kind of put forward, and then what the committee suggested in terms of where some of these different administrative functions should lie. So at a very high level, we're looking at the Public Corporation Central, which would really be kind of that centralized office, taking charge of the financing and budget, policy and legislation, designing a lot of the big policy elements, so payment systems, benefits, the quality strategy, IT, and overall data collection. Then we have this regional structure, what we call the Public Corporation Regional Offices, noting that we want them to have very much a role in really engaging the community and in being able to get information from the community and filter it up. So community engagement is first and foremost, that's their primary responsibility. We heard that loud and clear from this committee, from board members, and that was a strong recommendation from the Joint Task Force as well. Provider education, member outreach, some opportunities for local innovation, health resource planning and prioritization, and this particularly focused on behavioral health and primary care. So those sort of what we would consider really local services, and workforce development. One of the key things that we have added compared to what you saw last time was just noting that community engagement part, just to really put some kind of meat on the bones there, a little bit of structure around it. We are suggesting these regional advisory councils to be kind of formally a responsibility of the regional offices. And these would be advisory bodies, ideally two, one composed of providers in that area and one composed of participants or members, as we might think of it in health plan terms, in order to really get that feedback, in order to really drive a lot of that, provider education, provider improvement, member outreach, supporting public health initiatives, etc. Next slide. And then finally, just noting that we did provide within the proposal a detailed breakout of what we saw as the role of these regional offices. And this is just really summarizing that. So first and foremost, there is advising the board related to pretty much everything, since it all does trickle down to the regions, but advising them with respect to budgets, payment methodologies, quality measures, letting them know if there are any unintended consequences, essentially, of some of the policies that they're noticing within their region. We also do have managing a regional innovation budget, and this is something that they would have discretion to do in order to help foster connections between some of their providers across the care continuum, etc. This was something that was from the Joint Task Force that we have continued to carry through. Regional planning processes to look at healthcare needs, partnerships with community organizations. So those that can impact social determinants of health, as well as, of course, public health offices. We want there to be a strong connection between our healthcare and our public health. Assisting and advising communities. So again, that education component being really critical. We see this as part of the work of those advisory councils as well. Engaging with the public, again, partially through that advisory council, really promoting collaboration and supporting health equity. Of course, sort of being the kind of umbrella of all of this engagement and interaction with folks. And I believe that is it. So I'll turn it back to you for discussion. Thank you.
Thank you so much. That was a lot of material. Committee members, anyone have questions for Lee about the presentation, about content and the write-up, how we're thinking this might look? Anne, yay. Go ahead.
Hi, you know me. Just for purposes of clarity, I'd made some notes on page 4, 5, and 6 of the proposal. And essentially, the one gap that I'm seeing is we have innovation in the regions, and there needs to be some place where spread of innovation resides as an accountability. So I think that ends up going back to the administrative services area. And typically when I'm doing, or when I have in the past done organizational design, I've also sketched out the metrics we'll be using. And for clarity purposes only, because I thought this was excellent. This was really, really well written. For purposes of clarity only, you typically have inward focused measures on performance of the entire organization, and you have external focused measures on the service provided to your customers, so population health, health metrics, things like that. And I noticed that this was hinted at in the proposal, but that it needs to be clear. So performance evaluation and the spread of innovations would then be an administrative role. And they would also be the ones doing the data analysis on the external facing metrics.
Thank you for that comment. Lee, there's a section in the straw proposal that talks about dependencies. I wonder about those, the provider specific metrics. The dependency may be coordination with plan design.
Yeah.
Yeah.
Yeah,
And
typically because you have your HEDIS measures or
right,
whatever. So yeah.
exactly. And those external ones, such a great point, Anne. Yeah,
Yeah.
what are those like plan level performance measures? And so I think that can be an annotation to this larger structure of the
Yeah.
straw proposal, and absolutely something we can get our hooks into and define specifically.
Yeah, typically that's like your second level of detail when you actually lay out your balance scorecard and things like
Yeah.
that. But the wording needs to actually specify, innovation spread, internal and external performance measures and, that kind of thing.
Yeah.
So you're exactly right. Thank you. I was really impressed by this document. I was very happy.
Great. Sarah, hi.
Hi, yes. It would be easier for me to kind of assess all these points if I had a better sense of how many regions that we're thinking of.
I don't know if hopefully it's in the proposal. We did not specify the regions because we do want to leave it open, but I know we had discussed 5 to 9 as a range.
And if I may add in there too, one of the discussions is utilizing regions that are already in effect. So which in Oregon, there's a couple of different breakdowns, but one of which is sort of the emergency health system. And that has, although 8 numbers, there's a total of 6 regions divided geographically. And so, so if that is helpful. Again, I know, and then Bruce definitely has said this a couple of times. We don't want to be too specific, but I think, and if that seems right, that's something that we can add into that. Like this would recommend, utilizing pre-existing regions, or if this committee feels like that's a good thought, or so you guys get to say what you'd like in there. So please jump in.
Sarah, would you mind sharing a little bit more about why that came to mind? What are your worries about or thoughts about? Well, if there's a whole bunch that are small, or there's just too many or too few.
Yeah, I didn't recall that 5 to 9 number. And yeah, as I try to get the big picture, it's
Mhm.
just feels like a piece of the puzzle.
Yeah.
Yeah.
Thank you. Hi, Paula.
Hi, I was just thinking about the regions and I made some notes, but then I forgot to go cross map. But anyway, is making sure that there's not overlap, right? And did we already say that in there? Okay, thank you.
Excellent point. Yes, absolutely. That would be confusing. Yeah. I'm intentionally going to pause a little as we noodle on this just to make sure nothing's bubbling up. See if there's anything else that bubbles up. Mimi, go ahead.
This is just to help things bubble up a little bit. So what I was wondering, because this has been a discussion a lot, regarding, and Judy will appreciate this idea of quote unquote risk, and what this proposal means in terms of risk residing within the larger organization and not within these regional organizations. I wanted to be clear that that does not preclude there, say, being contracts between this, the public corporation and a provider group or a hospital, where there may be like shared savings or some type of upside benefit, or even, potentially there's the possibility of downside risk, but just that ultimately there is not a completely distinct regional entity that carries risk. And again, I'll just use the example of CCOs, as people are mostly familiar with that. All of the CCOs across Oregon do carry risk. If they go, if they lose money, they lose money, and it is not actually the state of Oregon if they overspend their budget. So to be clear, it would be this, sort of very large public corporation that would ultimately have that financial risk, big picture. So I just wanted to clarify that, and then see if people had thoughts about that. Like, well, I really think it's important for these regions maybe to be at risk or something like that. So, because this is going to be a big point, I think, for the board as well. And I don't know, Judy, if you probably could frame that question better than I did.
No, I think that's great. Yeah. Mhm. Hi, Doris. Go ahead.
Hi. Um, so with CCOs being in charge of their finances and budgets, I don't know if you've been privy to conversations. There's some CCOs that are operating in the red and they,
Oh, yes.
they need support. So I think it would be beneficial to have one big entity that is in charge of the budget so that things like this don't happen, because they're it's tight right now for a lot of larger CCOs.
Great point. Yes, thank you for bringing that one up. Paula.
I would just say I agree with that, but then there would need to be some accountability reporting, obviously, at the regional level to make sure, that oversight and compliance.
Yes, absolutely. Thank you, Lori. Go ahead. Um, we're having a hard time hearing you.
I know it looks like you're muted from our end, and every now and then it will flip, Lori, to look like you're unmuted, and then immediately flips back to you being muted. We do have a chat function now, if that's any benefit.
Oh, great, great.
I'm so sorry.
Yeah. Excellent.
Oh, okay. It works. Is that better?
Ah,
That's it.
Okay, that was my not noticing a detail on my headphone here. So I guess my question, when I think about the health equity, ongoing community engagement, we're not really touching the conversation around the tribal infrastructure with currently, or is that correct?
I would, in terms of what is within the proposal, you are correct. There definitely are engagement plans with tribal entities, absolutely. But
in terms of how they're going to fit
in terms,
into a regional structure, no.
not as of yet. How about that? There's nothing, there's no detail, let's put it that way.
Okay. That was my question.
That's a great point. Thank you so much.
Sarah.
Yes, especially since revenue or actually I think it's plan design that's been working on hospitals lately. I'm wondering on this third bullet down where it talks about regional planning processes to assess and prioritize regional health needs, focusing on primary care, behavioral health, and workforce development. I wonder if the word hospitals where relevant, I don't know if maybe not every region will have a hospital, but something like hospitals where relevant, something like that. Would that be a good addition?
I think it would absolutely, especially collaboration with other regions that may be the referring hospital, right? Yeah. I think that's good learnings we can take from the emergency management regional structure, for sure. Great discussion, everyone. Yeah, Lori.
One more comment. The incarcerated residents of Oregon, that's always been a very complicated thing with our current system. Has there been any conversation about that?
Carceral populations, Mimi, have they talked about that in PD&E?
Actually, no, and that's an excellent point, Lori, and I definitely appreciate it in terms of the overarching plan in terms of eligibility. People who are part of the carceral population are people residing in Oregon, and so they would therefore be eligible for this plan, but sort of how that would play out in terms of the interaction with the carceral system and the sort of, well, particularly on the jail level, but also in the prison level too, kind of the system that exists currently. So I think that's a great call out. So thank you.
Do we imagine the staff at regional offices and or the advisory councils being employees of the public trust entity? I don't remember we were talked about that.
Yes, so that was one of being that one of the concerns was about, the profit status as well as folks, needing to hold separate reserves from the public corporation. One of the points that we had discussed and there seemed to be general agreement on was that these regional offices, yes, would function within the public corporation. So they are closer to the ground, but there is no separate need for them to hold any kind of reserves. They won't have any profit status distinct from the public corporation itself.
Excellent. Great. Hi, Doug. Go ahead.
I have a question, and maybe this has been discussed previously and I missed it. When and how will the regions be determined? Who will make that decision and when? It's critical, obviously, for all kinds of reasons.
I'll give a shot. I imagine that will be part of the transition planning process. So our committee operations will hand off to transition. And so that essentially gets the lay of the land and makes the plan to implement all this great strategy that we're putting together. Anyone else want to? You can say I'm wrong. That's a guess.
I would just like to add into that is that this committee, we're really hoping to hear from you. So if you think absolutely there need to be 314 regions, I mean, I hope not, but we'd want to hear your evidence for that and why, or other rationales as well. So this is really, I mean, you all are really part of this is not necessarily this is not the final decision-making body, but you are providing a lot of the content of the discussion that will go to the board and will go to the other groups.
Have there been any preliminary thoughts on this? I recognize that I saw in the documents you sent out. Thank you. I agree with no overlapping areas. That would be a huge mistake. But also, I mean, I agree with also the language about looking for natural service areas, natural areas of travel and commerce, if you will. That gets tricky though in some cases. So
Absolutely. I imagine it will be similar to how we made decisions about public trust. We'll interview several different participants in other structures, like the emergency management regions, like counties, like school boards that don't overlap, that kind of thing, and think about how does this make sense? Probably get some input from economists who can say, how do you spread risk in a way that's sustainable and make it available, most accessible to the folks who are getting the care. But yeah.
would there be an office in each region?
Yeah, I think that's as Lee presented.
And there'll be staff in the offices. Now, will the staff there'll be staff, all one big staff, if I use that, both for the central and the regional offices are all the same. They're all staff, same policy, same personnel policies, etc.
That is what we are proposing. So if you have a different idea, fire
No,
away.
not at all. Not at all. I really want to clarify. Yeah.
Yeah, no. Thank you. And exactly that is a thought. And again, this is
one
this
team.
week. Absolutely, one team. Well, I will just share that at an earlier, forget who I presented this to. I think I put up a slide that sort of had the regions, but showing in all sort of horizontally going across and then some vertical things. And they're like, whoa, 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 whoa. That just looks like so much bureaucracy. We want to make this clear that because of course part of this is the effort to really reduce the sort of administrative burden and really have efficiencies. And so that is why this part of this proposal is the way it is. Certainly, but yes, so you all get to be the architects of some of this. So thank you.
Lori, go ahead.
I was thinking of the impact or the complexity or how you would spell it out in this structure. OHSU is kind of a tertiary care center and would probably play a bigger role in terms of serving the community, the state. And I just wondered how that would be factored in here as a part of looking at regions.
Lee, do you want to take a stab at that, or I can say
I'm not
what we're
sure
thinking
I
right now?
completely understand the question. Yeah, I'm not sure I understand the question, so go for it, Mimi.
Well, I think one of the things for us all to keep in mind, although of course we are talking about regions, one of the tenets of the Universal Health Plan is that people are able to get care at any provider. So
Sure.
I want people to remember that we're not talking about a quote unquote network. You know, like, oh, I need to go to this particular hospital because that's nearby where I live. So absolutely kind of keep thinking of the tertiary care center being serving the entire state. I think if that's what you're getting at, Lori, and that is, you know, there's a lot of discussion right now about, you know, payments for hospitals and the potentials for global budgets for hospitals and things, and that's kind of happening at the plan design and expenditure committee meetings. But again, really trying to, almost like thinking of Oregon as really kind of, you know, just based on size, is one giant region. And within the state, we have all of the resources we need. But even, you know, you could divide the state up into only 6 regions, and certainly every region would not have all of the healthcare resources that they needed. So really, I think as Lee kind of, I think that was one of the things that we were thinking about in terms of where some care is much more likely to be regional, and then some care just by default has to have that sort of central backing. So that was a lot. I'm not sure if that answered your question.
I was just thinking of it in terms of the overlap issues. A couple of things. One is that chronically ill people may be spending a good amount of time around OHSU as opposed to their, you know, home communities, and what that means and how that looks like. And obviously the cost and the resources for a more complicated population in, you know, if not temporary, but kind of the way things are, it comes down to, I think, somewhat the conversation, and it's not really our purview here, but how you figure out resources based on numbers versus complexity versus, you know, the tertiary usage, for instance, in the Portland area, and how that would, you know, impact that region in general.
You know, especially post-COVID, I see, and I've witnessed a lot of movement of people with primary care in particular, much farther away than historically would have been the case. They might live in Grants Pass and have a PCP in Portland. I mean, I see it's happening, and it's something that has to be, you know, it's not going to go back. Is my observation. And that's not a lot. It's not a significant number, but it's there, and it could be back to some of the people you're talking about, Lori, in terms of the complexity.
Thank you for both of those comments. You really make me think that this is really more evidence for why regional entities should not be risk bearing. Because then, if they were risk
Exactly.
bearing, yeah, right, you'd be really worried about attribution and keeping within your global budget and your own little pie. But if they're not risk bearing, then there's more fluidity across regions. Paula.
Yeah.
I was just thinking of another word too of regional hubs as integrators. So I don't know. And so anyways, that just came up, and you know, there's a lot around that, but being able to connect and coordinate diverse activities. And so I like that word, but just wanted to mention it.
Love that. Paula, you and Anne made me think about learning health systems, you know, learning systems, and how we integrate and disseminate innovation and continually learn and improve. Boy, wouldn't this be a wonderful opportunity to take advantage of learning health systems and continual improvement? Yeah. Sorry, all stuff that doesn't have to be in this draft proposal, but I know that Lee and Isabel are taking notes, and we can put some more meat around this bones, and definitely it'll be in the report. Sarah.
Yes. Have we discussed at some point whether, obviously we have a board right now, but after the transition, will there still be a board of the Universal Health Plan, since that word is showing up here and there in this document?
Thank you, Sarah. Yes, as a public trust, it will need a governing board. It will not be the same board that is in existence now doing this work and making the sausage. They'll be the ones who are the governing board of the Universal Health Plan Public Trust.
I feel like that word board is maybe honestly like a bit on the wonky side. And as sorry, I do have a bit of a communications background, so I'm always thinking from a communications lens too. But I don't know if people, kind of trying to tune in and read this would know what that means, since so many large things are also not run by a board. So I wonder if like maybe just brainstorming like the word leadership might be helpful. Like that, just looking at this slide here, like advising the board and the leadership of the Universal Health Plan, something along those lines. Yeah.
Thank you for that. Go ahead, Doug.
Yeah, this may be a small item in your mind, but I noticed in the documents, we never mentioned oral health. And from experience, that component was always a challenge of its own. And we need to acknowledge it somehow that it is a covered benefit, as I understand. And I recognize you're talking about primary care. It's primary oral health care as well, obviously. And but you might want to mention it somewhere in there that it is part of the package for the planning process. They're a unique group to pull together. Yeah.
Yeah, I'm thinking about how the DCOs came into the CCOs and what a challenge that was. And I'm sure that was coming to mind too. I don't know if or where in this draw proposal come out, but yes. Yeah, Sarah.
Yeah, I don't know if I'm getting too far into the weeds here, but I feel like there's a little bit of overlap or redundancy in 1, 2, 3, 4, 5, the fifth point that talks about assisting and advising communities on delivery systems, innovation, quality, and cost control efforts. And I'm seeing the word quality in the second bullet. I'm seeing the word innovation in another bullet. I'm seeing talk of budgets and costs in another bullet. So if it's worthwhile to cut down any of this wording and see if any of those redundancies could be streamlined. But if not, I don't see any problems with a little redundancy really either.
Absolutely. Cannot get too weedy. Bring it on. I just want to say that all, uh, thoughts, words gratefully accepted, because I agree that I think if we think about future selves trying to interpret this, they could be saying like, do they mean something different? What are they trying to say? And I appreciate that thought of like just being, we don't want to leave anything out, absolutely, but we also want to really try and be clear.
How is everyone feeling generally about this concept coming to the board as a straw proposal? And just to remind you of the straw proposal process, the intention of the board in putting together the form of the straw proposal was to communicate with committees when committees have an idea or a direction in the work that we want to take on and where we want to go. Being able to communicate that to a board is a check, and the board will review that proposed direction and say, yep, you're going in alignment with what the board wants and needs, or workshop that a little bit. It's not in alignment with this, that, or the other thing, or we have questions in how this fits together with the overall body of work. So with that being said, this does not have to be perfect. The intention is to be clear enough so the board understands that we're recommending this structure, this sort of structure to regional entities, and the big bullet points of they're not risk bearing, they won't overlap. The intention really in this language is that it feels bi-directional to me, the engagement with community, and then also the education and assistance and providing advisory roles in accessing care. So how are you all feeling about sending this on to the board? Yeah, Paula, what do you think?
Yeah, I think this is a great point to do this. It looks good to me, and I think it would be great to get that feedback and make sure that, you know, there's anything that comes up or that's different than what we're thinking, but I'm good with it.
Cool, okay, bueno. Any other discussion? Yeah, Lori.
Well, I was
Oh, go ahead.
really impressed with, after all our conversations we'd had in recent meetings, I thought this really incorporated things quite well. The skeptical part of me worries the most about pharmacy and how it's going to fit into this, just because there's so many issues with currently with, mail order versus just, and, how you would control or the pharmacy benefit manager piece of it, and how it interacts with supply and demand, thinking about other states. I mean, there's just a lot of things that I worry about regarding pharmacy. But other than the fact that that worries me, and that's not for us to figure out as an operations committee right now. That's the only thing I would say that still feels like it's not really figured out.
Agree, I'm right there with you. Wakes me up at night too. Hey, Doug.
The pharmacies are going through big change right now. I agree with that. So I just want to reiterate that the regions, if you will, the regional map, that needs to be carefully thought through, and make sure you get the right folks there looking at that together. That could really be a deal breaker in the long run in terms of cooperation.
Wise words, absolutely.
Since I was just going to ask to follow up on that question, Doug, are there I feel like there's something that you're thinking about Like, I specifically think, and so if that is true, then definitely you don't have to say it now or email it or something, but really, we did have, so I think what happened, we did a little bit backwards to this. We did some presentations to the board that had a little bit more detail about talking about the different types of regions and like the Dartmouth plans of hospital regions, et cetera, et cetera. But if there is something that you're like, I really, either geographic boundaries or what's already in existence, please. Again, you don't have to say it now, but if you, please share. That goes for anyone.
Nothing magical. Just, I mean, the reality is we're dealing with a very important topic and lots of money. And that gets people's attention. And we're going to ask people to make some major changes too in this process. And I just think, it's critical that whatever we do, we don't inadvertently some people together that could be a problem. It's not going to be easy because there's always going to be issues no matter what you do. No matter how you slice it up, there's somebody's not going to be totally satisfied. But I think the easiest one is no overlaps. I think that's well stated. I agree totally with that one. That's gonna be hard in the metro area, but it's just you're dealing with a lot of money and a lot of emotion. So it can be done though.
And
Yeah, just a clarifying question. Doug, are you suggesting that we come up with criteria for making a decision about regions?
I guess sort of. That we do that, or we have at least start off with a group of folks, with this whoever it is, to look at Oregon and think about it, and think about the history. Most recently with the CCOs, but go back beyond that, the historical and yeah, I mean, I'm not sure if there are specific criteria can be applied right now. A lot of history though.
I love that idea. Mimi, let's talk about this as a future agenda item to invite folks who have, I want to say stakeholders, but folks who have knowledge and expertise that can come and talk with us, because it will be a great way to share with them the work we're doing as well. I'm thinking like county commissioners specifically, or public health officers, or other folks who may be spread throughout the state who can give us a really strong sense of the flavor for their specific region. And then, yeah, I love that. And that can be subsidiary to this straw proposal, doesn't have to wait for that. Great. Are we ready to go ahead and take a formal vote on sending this on to the board? Any other discussion? Isabel, will you go ahead and call a roll call?
I will. Okay, Bruce Goldberg is absent. Judy Richardson.
Yes.
Thank you. Laura Byerly. Laura Byerly, are you able to give your vote right now? And if not, we'll come back around. Okay, we'll circle back. Doug Flo. Doug, are you able to give your vote? Guess we'll come back. Sarah Fouché.
Yes. Oh, here comes Doug unmuted.
Oh, thank you, Laura. I see you in the chat. And then Doug, do you have your vote?
Yes.
Thank you. Sarah Fouché.
Oh, I said yes.
Okay, great. Lori Hoagland.
Yes.
Thank you. Michael Jorge is absent. Doris Caragu.
Yes.
Thank you. Rosalind Lindsay is absent. Anne Lovejoy.
Yes.
Thank you. And last but not least, Paula Weldon.
Yes.
Thank you. That's everyone.
Excellent. Thank you, everyone, for your thoughtful comments. I deeply appreciate all of those, and I know we'll be working to incorporate them in our report as we continue on this work for regional entities, and then also bring some invited stakeholders to the committee so they can talk about their experience in being a region as that was defined for them. All right, the next thing on the agenda, committee member reflections and next steps. The next steps for this straw proposal will be that it will go to the board, I believe, in the October meeting for their reading and any feedback that they may have for us. And then that will come back to the committee as part of our work. Other reflections. Mimi, do you have anything else on next steps?
No, but I do know that our friends from Milliman will be working hard and coming up at our next meeting as well with some of their findings and suggestions. So looking forward to that.
Excellent. Great. Okay, this brings us to public comment. Val?
Yes, so we have one sign up for public comment today. As always, we really appreciate members of the public listening in and providing public comment. Public comment can be provided at any time via our website. We ask for written public comment to be submitted at least 72 hours before a meeting so we can incorporate it into the materials. And for oral public comment, people can sign up at least 24 hours in advance. And we limit public comment to around 2 minutes. And so if there's anything that is not able to be shared in those 2 minutes, please submit it either as another sign up or in written form. But with that, oh, Sarah, I see your hand up.
Sorry, as I'm realizing this is maybe my last chance before public comment. So I try to listen to finance and revenue and plan design meetings as much as possible. And given that, we talk about administrative costs and administrative percentages, and our committee is probably feeding into both the budgeting aspects. So, and personnel is always such a big expense item. Won't it be more difficult for both finance and revenue and plan design to figure out this blueprint that we're trying to all build together if we're as vague as we are? Might be 5 regions, like aren't we going to need to drill down? Well, maybe it's not us, but maybe it's, who is it, expenditures or something? Isn't somebody going to need to drill down into, how many administrators, how many staff? Is it 15 staff times 9 regions? Is it 5 staff times 5 regions? I think those are maybe big enough numbers that people need to look at those before 3-4 years from now.
Yeah, absolutely. 100%. I think the first step is we need to make sure that the board agrees with what we think about regional entities and then continue along that workflow just as you were articulating. And it's like a yes and, right? All these boats in the same direction. And so once we know from revenue what the revenue's going to be like, we'll hear from plan design what the expenditures are going to be like, and then be able to calculate a percentage for administrative costs. It kind of constrains, I think, a little bit how many staff you can get. But yes, absolutely, they're going to need to hear from us how many regional entities. And when they have a straw proposal that has a dependency on us that articulates that, hopefully we'll have it already in the can and we can say, here's what we think. And that's what my hope is in inviting experts to give us feedback and like really inform us about the risks and benefits of dividing up the state in certain ways. And have those conversations in advance of the dependency that's needed by the other committee. Yes, absolutely. Mimi, do you have anything to add to that?
I was going to, not to put Kate on the spot from Milliman, but I wondered if Kate, if you don't mind, talking a little bit about the information that you anticipate being able to share with this committee. And if that's not possible, that's okay too.
That's okay. Hi, everyone.
Thank you,
We
Kate.
are sure. What we hope to present to this committee is really what administrative costs will look like. And I know you don't have a regional number yet in mind, but that's why we like to iterate with all of you. We'll come up with a couple different scenarios and talk through the pros and cons of both of them, like we did in our last committee. Here's the pros of having a regional committee versus centralized structure. And so we hope when we come back to you, we've got a couple of different options, and you all as experts and residents of the state of Oregon will let us know which seems most feasible, and we'll build out the cost from there.
Thank you, Kate. Coming to
Of
my
course.
rescue.
Yeah.
Thanks for the question, Sarah. Any other discussion before we get to public comment? All right, Isabel, you can introduce the public comment.
Great, thank you for your patience. Lou, we will hand it over to you to share your comment.
Okay. Can you hear me?
Yes.
Oh, good. I can't see me, but okay. This is the first session that I've been disappointed in. I know everybody's working as hard as they can, but I want to remind everybody that the risk taker is not by region, it is the whole state. And I think it's a great idea to do visits around the state and have that get immediate feedback by a group of people. That's how the CCOs got started. I thought that was pretty lively. But to break up into regions is a ridiculous idea in my mind, because it's better to have it centralized. I keep thinking that everybody wants to build a better system. Just take the system it is and let the public pay for it. Keep it simple. You're trying to build a Cadillac. I think you ought to start out with a Chevy, okay? I just cannot extend. I am going to urge everybody I can to vote no on this. Thank you.
Thanks for your comment, Lou. I noticed that you joined our meeting a little bit late. I would encourage you to go back and watch the first part of the meeting, because Lee really presented a great presentation that's not aligned with your comment. So that content is there for
It's
you
going to
to
cost too much.
take your time.
Hate the idea.
Any other comments? Thank you
That was
all for
our only sign up today.
Okay, great. Thanks, Isabel. You can unshare. Thanks. Go ahead and stop share. Great. Everyone, thank you so much for your time today and your time reading the materials in advance and joining in on the discussion and your deep thought and comments that you've brought to our work. I really appreciate you individually, and I appreciate this group collectively. Thanks, everybody. I'll see you next time.